Good evening and welcome to the actually first but second actually, in the sense that we had the December meeting in January. So this is actually the first meeting of January. So I hope with the Omicron coming and now deciding to go, we should be maybe like everybody is predicting, free of corona, and it may remain only as a minor illness. And the last year and the year before last, 2 years, we have done everything virtually. But we have found that doing these monthly meeting virtually is a good idea because more people can attend and, participation is more. So maybe we'll continue like that. So the new thing in this year, what we have done is that last time we had a GBM in which we got the constitutional amendments passed, and now it has gone, it is in the process of being finalized legally. So that will come very handy to the new team who comes, because everything is, clear what they have to do, how it has to be done. So that would be one good thing. This new team will have, they'll have clear guidelines to do whatever they have to do. And we have had a lot of academic programs in the last year. But what I found lacking is that we have so much clinical material, but nobody writes in, index journals. So we are starting a series from 31st January in which, we will enroll people. The first session is going to be for everybody. After that, we'll have session only for interested people, how to write their articles and how to review the literature. That series we will have from 31st January onward. And I hope this year would be better, as everybody has predicted, all the Joshi Chara, everybody has predicted this is going to be a good year. So hope for that. And now, has Monica joined?
Yes, ma'am, I'm here.
Okay, so welcome back, Monica, after how many turns?
I think 2 turns I missed.
So please give the secretary's report.
Yeah, sure, ma'am. Is my screen visible?
Yes. Yes, Monica, it is visible.
Okay, so regarding the events held from the last AOGD clinical meeting till today, this is again the glimpse of the meeting which we had in Gangaram Hospital on 7th January, a well-attended one. Then amongst the AOGD events, we had this program on translating contraceptive evidence into clinical practice by Foxy Family Welfare Committee in association with AOGD, which was held on 22nd January. Then there was this Evolve program, which was a joint initiative of Delhi and Haryana. And this was again a national level program. Then at the national level in the ICOG convocation, the critical care course, which is being conducted by our senior AOGD members and Vice President AOGD, Dr. Pratima Mittal and Dr. Jyotsna Suri, was explained upon and was commended upon. This is one of the very important weekend courses which ICOG is conducting and is being regularly held. AOGD General Body Meeting was held on 7th January, in which, as ma'am has already said, important agenda was discussed, which was passing of AOGD Constitution Amendment. And there was call for AOGD President, Vice President nominations and chairpersons of various important subcommittees whose position was being held vacant. And passing of audits of account for the financial year 2020-21 was done. Amongst the events done by our various subcommittees, a program on adenomyosis was held on 21st January, which was in association with DGFS and IAGE Delhi chapter by AOGD Endometriosis Subcommittee. Then we had a very interesting and very well-attended public forum, which was just held yesterday on screening and prevention of cervical cancer with Adolescent Health Committee of FOXY. This program was done by AOGD Oncology Subcommittee. Then we had AOGD Endoscopy Subcommittee event again, which was yesterday, on energy sources in endoscopy and imperative art. This was in association with IAGE Delhi. Amongst the forthcoming events, which will be held from now on, there'll be a webinar on research methodology, very interesting program, especially for the postgraduates. I must attend one on 31st January. Then there's a program on optimizing nutrition and mental health of adolescents by Adolescent Health Subcommittee of AOGD on 3rd February. Then a CME on breast cancer by Multidisciplinary Subcommittee with the FOXY Breast Committee on 5th February. Webinar on pregnancy in thalassaemic women by Quality Improvement Subcommittee on 16th February. Then there'll be a program on delving into clinical concerns of intrahepatic cholestasis of pregnancy by Safe Motherhood Subcommittee on 19 January. PG Forum, as we are regularly having classes again, this time the class will be on recurrent pregnancy loss on 21st February. CME by Endoscopy Subcommittee, the topic is yet to be told on 24th February, and a CME on breast and ovarian cancer by Oncology Subcommittee on 26th February. Now, one interesting announcement, as ma'am had already said, we had invited nominations. So to all of you, we are declaring what the nominations we have received. For the AOGD President and Vice President 22-23, nominations received are from Dr. Asmita Rathore, from Maulana Azad and LNJP Hospital. And for Vice President, the nomination is from Dr. Y.M. Mala, Maulana Azad and LNJP Hospital. Amongst the subcommittee chairpersons, the nominations which have been received are for the Breast and Cervical Cancer Awareness, Screening and Prevention Subcommittee. We have received a total of 5 nominations. Dr. Meenakshi Ahuja, Dr. Poonam Goel, Dr. Mamta Dagar, Dr. Seema Prakash, and Dr. Mrinalini Mani. For the Infertility Subcommittee, the nominations are Dr. Manju Khimani, Dr. Sunita Arora, and Dr. Bindu Bajaj. For the Rural Health Subcommittee, a single nomination from Dr. Shivani Agrawal has been received. And for Multidisciplinary Subcommittee, Dr. Kiran Guleria and Dr. Rekha Bharti have applied for the subcommittee. So our executive committee is going to delve over the nominations and the details received, and soon the results will be announced to all of you. As regards the next clinical AOGD monthly meeting, it will be held in UCMS and GTB Hospital on 25th February 2022. So looking forward for the next meeting from now on. Thank you all.
Thank you, Monica. And now I hand over to Dr. Ashok, HOD RML Hospital, for the monthly clinical meeting.
Thank you, President Fox, AOGD, Dr. Achila Pattara. Good evening. Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital welcomes you all for this January month AOGD meeting. And as the tradition of these meetings, we are going to present 3 cases which are uncommon, and we have 3 units in the department, and from unit 1 headed by Dr. Bengali Maji, the presentation is on recurrent ovarian tumors. In fact, it was a torsion of ovarian tumor on the contracted side. The second unit headed by Dr. Indu Chawla, and her unit will be presenting a case of ovarian microcystic stromal tumor. Third unit is will be presenting the case of unusual tubo-ovarian mass, the final diagnosis which we will be going to discuss in the end. So I hand over the proceeding to Dr. Kamna Datta. She is professor in the department for coordinating and presenting these cases. So Dr. Kamna.
Thank you, sir. A very good evening and a warm welcome to all esteemed faculty, AOGD President, Vice President, all executive members and office bearers. We at Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospital take it as an honor to host this monthly AOGD meeting. We start our session quickly. The first case will be presented by Dr. Ayushi. She is our second year postgraduate student, and Dr. Neha Pruti Tandon. She is assistant professor at our hospital. Dr. Ayushi, please.
Thank you, ma'am. Good evening, seniors. I am Dr. Ayushi. I'll be presenting a case on recurrent ovarian torsion in an adolescent. 17-year-old unmarried female presented to RML casualty on 17 September 2021 at 12 a.m. with chief complaints of severe pain abdomen with vomiting since 1 day. The patient developed pain lower abdomen on left side 1 day back, which was sudden in onset, intermittent in nature, severe in intensity, non-radiating, associated with nausea and vomiting. There was no history of preceding amenorrhea, no history of fever, chills, diarrhea, constipation, jaundice, no history of burning micturition, dysuria, hematuria. Patient denied history of being sexually active. Patient had a history of similar episode of pain 2 years back on 17 September 2019 when she was 15 years of age. Coincidentally, on the same day as the patient presented this year, the discharge paper was reviewed, which mentioned that the patient had fever with anemia and pain abdomen and received 3 units of blood transfusion during the hospital stay. Right-sided salpingo oophorectomy for 14 by 11 centimeter large necrotic hemorrhagic ovarian mass was done. Left ovarian ligament was noted to be 4 to 5 centimeters long and prophylactic left oophorectomy was done. In the menstrual history, patient retained menarche at 14 years of age. Her last menstrual period was on 14 September 2021. Her cycles were irregular since menarche, occurring every 2 to 3 months, lasting for 7 to 8 days, with heavy flow, not associated with passage of clots or dysmenorrhea. On examination, the patient was conscious, well-oriented to time, place, and person. Hydration was fair. There was no evidence of pallor, icterus, pedal edema, cyanosis, and clubbing. Her blood pressure was found to be 110 by 70 millimeters of mercury. There was tachycardia with the pulse rate of 110 beats per minute. Respiratory rate was 18 per minute. And the chest and the cardiovascular system was found to be normal. On per abdomen examination, there was tenderness present in the left lower quadrant with guarding, no rebound tenderness, and no free fluid or mass was palpable. On local examination, the external genitalia was found to be normal. The provisional diagnosis of a 17-year-old adolescent with left ovarian torsion was made. On investigating the patient, her routine blood investigations were found to be within normal limits. On ultrasound pelvis, transabdominal scan, the uterus was found to be of normal size with an endometrial thickness of 8 mm. Her left ovary was enlarged, measuring 6.2 by 4 by 5.17 centimeters, which was mildly echogenic, with stromal edema and with a small peripheral cyst. Clinical impression of left ovarian torsion was made after reviewing the ultrasound color Doppler transabdominal scan, in which left ovary was seen with absent color Doppler, color flow and Doppler. Patient was taken up for emergency laparotomy. In the intra-op findings, left ovary was found to be enlarged with an ovarian cyst of 4 by 4 centimeters with 2.5 twists of turns present. The left ovary was detorted and left-sided oophorectomy was done using the hot dog in bun technique. In the follow-up period, the patient reported to have regular periods. Ultrasound color Doppler transabdominal scan was done 2 months post-operatively, which showed normal left ovary with normal flow on Doppler. Her serum AMH levels were found to be normal. Now I hand over to Dr. Neha for the discussion.
Good afternoon, everyone. Ayushi, move the slide. Good afternoon, everyone. We begin with the discussion. As we all know, adnexal torsion is a surgical emergency requiring prompt intervention after clinical suspicion. Torsion is usually seen on the right side as the infundibulopelvic ligament is longer and there is absence of sigmoid colon. Torsion is seen in normal ovary in adolescents in about 46% cases. Next slide. 30% of all cases of adnexal torsions occur in female less than 20 years of age. Incidence of torsion in adolescents presenting with pain is around 2.7%, and the recurrence rate is around 11 to 18%. Coming on to the risk factors for adolescent torsion, adnexal mass is the most common factor in adolescents. It is mainly the functional cyst or a benign ovarian mass, which is more than 4 centimeters, which torts. However, in adolescents, normal ovaries have also shown to undergo torsion. In other age group, other factors, risk factors include ovarian hyperstimulation, pregnancy, and previous ovarian torsion. Causes of recurrent ovarian torsion include congenitally longer uterovarian ligaments, excessive laxity of ovarian ligaments, small uterus. All these lead to twisting of adnexa on its axis. Increase in intra-abdominal pressure due to constipation or excessive physical movements as in athletes can also lead to recurrent ovarian torsion. Now, amongst the adolescents, we have two groups. One is the premenarchal and other is the postmenarchal. The torsion in the premenarchal patients can occur with or without an adnexal mass. It has been hypothesized that uterovarian ligaments are normally longer in premenarchal girls, which facilitate ovarian torsion. And these ligaments shorten as the girl matures through the puberty. In one of the case series, they have also said that the presentation in premenarchal girls differ than that of the postmenarchal. The premenarchal girls present with a diffuse pain rather than a localized pain. We had reviewed the literature and we found that the Smogig et al. Had done a study on these two groups of patients, premenarchal and postmenarchal, and he found that recurrent torsion is more common in the premenarchal, around 35%, and 4.2% in around postmenarchal girls. The recurrence is seen more in normal ovaries in the premenarchal girls, around 70%. In both the cases, ipsilateral oophoropexy was done for the first time. And in the second case also, the oophoropexy was done on the other side because of torsion. Next slide. Now, whenever an adolescent presents with an acute abdominal pain, the first investigation we go for is the transabdominal ultrasonography. If the findings are suggestive of ovarian torsion, like enlarged ovary, asymmetrical ovaries, whirlpool sign, multiple peripheral follicles, we should directly proceed with diagnostic laparoscopy. However, if the findings are normal and the pain is persisting, we have to rule out other causes. If the pain resolves, in that case, we have to observe the patient and we should be aware of the term intermittent torsion. Mainstay of treatment for ovarian torsion is swift operative detorsion to preserve the ovarian function. Traditionally, oophorectomy was done as it was hypothesized that on untwisting, there is going to be thromboembolic phenomena and it will also lead to infection. However, currently, oophorectomy is done only in cases if the ovary is necrotic, there is suspicion of malignancy, and in postmenopausal females. The methods to prevent recurrent torsion are mainly surgical, that is oophoropexy, which will be discussed in our next slide. The medical management includes the role of OCPs, which is controversial. Low dose of OCPs can be given to postmenarchal adolescents. However, they cannot be given for a longer time, and particularly when there is contraindication to the combined pill. Next slide. Oophoropexy is a surgical procedure in which the ovary is fixed to limit its range of movement. There can be plication of the uterovarian ligaments, or the ovary can be fixed to the pelvic side wall or the anterior and posterior abdominal wall, or a combined approach can also be followed. However, we have seen there are case reports that there have been failure of oophoropexy and there is always a search of a newer technique. One such technique is the hot dog and bun technique. In this technique, the uterovarian and the round ligaments are used as a bun, while the fallopian tube is placed as a hot dog in between. This can be used with or without the shortening of the ovarian ligaments. What is done in this technique is the suture is passed in an atraumatic fashion from the uterovarian ligaments, following the clean area of the mesosalpinx and then the round ligament, and it is brought back in the opposite direction and tied. The advantage is that it is going to limit the mobility of the longer ligaments, and it is also going to prevent the tube from getting crushed. We also searched the literature for the hot dog and bun technique. The oldest case report was in 2012 by Kondrup. He applied the stitch on a 12-year-old girl. In India, this stitch has been applied by Shah et al. In a 17-year-old girl and has kept that girl on follow-up and has shown good results without any recurrence. Only one case series has been reported in which 14 patients of age group 8 to 33 years were used and this technique was applied. Recurrence was seen only in one patient, and particularly when absorbable suture was used. No recurrence was seen with non-absorbable sutures. Next slide. Another technique which was told by Deepak Lambachia was ovarian bivalving along with oophoropexy. In this, an incision is made on the most dependent portion of the left ovary. This technique is said to decrease the intracapsular pressure and to increase the arterial perfusion and thereby speeden up the recovery. Next slide. Now, there is always a confusion whether we need to do a unilateral or a bilateral oophoropexy. As of now, no high quality data or a guideline available to prove the efficacy of this approach. We have to decide on case-to-case basis. If the ovarian ligaments are longer, it is better to go in for a bilateral oophoropexy. Also, if there is a previous oophorectomy and if there is only one ovary is remaining, in that case, oophoropexy is a must. As the complications of oophoropexy are very, very rare, it is a safe technique. Of only one case report of risk of bowel entrapment has been seen in which the stitch was applied to the posterior abdominal wall. Next slide. We have reviewed the literature using the PubMed and Google search engines, and we found 2 case reports and around 10 retrospective studies in which our findings were also confirmed that the right-sided ovarian torsion is more common than the left. The torsion is seen in around, recurrence rate is seen around 9 to 18%. And the recurrence is more common when only detorsion is done, and the rates decrease when we do oophoropexy. So now when we come on to the summing up of the cases, we should have a strong suspicion of ovarian torsion whenever an adolescent is presenting with an acute abdomen. Ultrasound is more sensitive than Doppler, and Doppler alone should never be used only to make the clinical decision. Timely intervention is a must to preserve the ovarian function and future fertility. Minimum invasive surgical approach is recommended. Oophorectomy is not the first choice. Inspection of contralateral ovary and ligaments should be done in the same sitting, and oophoropexy can be done if the ligaments are long. The newer techniques like hot dog and bun require larger studies and longer follow-ups to be recommended. In the end, I would like to say a clear vision with an appropriate strategy coupled with a timely action can be a savior for an ovary for an adolescent. Thank you so much. I would now like to hand over to Dr. Durgesh and Shalini for the next case.
Good afternoon, everyone. I am Dr. Shalini. I shall be presenting case on ovarian microcystic stromal tumor. This tumor is quite rare and was classified by WHO for the first time in 2014 and was placed in the benign category. However, the presentation of this tumor in our case was different from the 57 cases described in the literature. Henceforth, we are presenting the case. My patient, Miss X, 17 years old, unmarried female, was admitted from gynae OPD with chief complaints of abdominal distension and pain abdomen since 1 month. Patient noticed distension of abdomen approximately 1 month back, which was gradually increasing and reached the present size where the patient had difficulty in breathing and lying down. This was associated with pain, which was initially dull ache and intermittent and later increased in intensity and duration and was relieved with medications only. There was no history of vomiting, weight loss, melena, though she gave history of anorexia. There was no history suggestive of tuberculosis. There was no history of altered bowel or bladder habits. Her menstrual history was unremarkable and her previous menstrual cycles were regular. There was no significant past or family history. On examination, she was average built with BMI 21.3 kg per meter square. Her vitals were stable. Pallor was present and clinically her hemoglobin was around 7 g/%. Pedal edema was present, which was bilateral and pitting. There was no lymphadenopathy and rest of her general physical examination was normal. On chest examination, bilateral reduced breath sound was present, which was infrascapular and more so on the right side. Her CVS examination was normal. On per abdomen, there was generalized abdominal distension. An abdominopelvic mass corresponding to 32-week size was present, which was irregular and ill-defined, firm, non-tender with restricted mobility, and free fluid was present. External genitalia was normal. On her routine blood investigations, her hemoglobin was found to be 6.4 gram%. Her serum proteins were low, and rest of the routine blood investigations and urine investigations were normal. On chest X-ray, bilateral pleural effusion was present with right-sided middle zone atelectatic patch. The patient had got an ultrasound report and CECT report, which were done 15 days prior to reporting to our hospital. In this ultrasound, upper abdomen was normal, uterus was normal size, an irregular massive solid cystic mass was present, which was arising from the pelvis, reaching up to xiphisternum and replacing the abdominal organs. Both the ovaries could not be visualized, and there was no evidence of peritoneal fluid in this. Her CT findings were consistent with the ultrasound, and in this, a large solid cystic mass was present with thick septations, which were pushing the bowels. On CT chest, there was a mild right-sided pleural effusion present. However, there was no evidence of any ascitic fluid or lymphadenopathy. Her repeat ultrasound done in our institute showed the same solid cystic mass and the development of ascites over the past 15 days. So with the differential diagnosis of germ cell tumor and sex-cord stromal tumor, patient was worked up for laparotomy. Amongst her tumor markers, CA125 and AFP were raised, which were 456 and 49 respectively, and CA19.9, CEA and LDH were within normal limits. Upper GI endoscopy was normal. She received three Paxil transfusion to correct anemia, and diagnostic pleural tapping was done, which was negative for malignancy and tuberculosis. While the patient was being worked up, she developed acute distension of abdomen. This on the 10th day of admission. This was associated with dyspnea, pallor, and hypotension. Urgent ultrasound was done, which revealed evidence of hemorrhage in the ascitic fluid, and the same was confirmed by tapping. So, with suspecting germ cell tumor and due to deteriorating condition of patient, decision for immediate laparotomy was taken. In this ultrasound, we can see a solid cystic mass and the ascitic fluid with echogenicity and the floating septations. Suspecting hemorrhage, emergency exploratory laparotomy was done under general anesthesia. On per of findings, approximately 2.5 liters gross hemorrhagic fluid was drained. A huge solid cystic mass was seen with approximately 20 into 20 centimeter solid component present anteriorly. This was tan colored, smooth to bosselated surface, was completely replacing the left ovary, and had a distended tube seen over the mass. On posterior surface, there was evidence of capsule rupture, and the solid mass had separated from the cystic component, which was earlier seen as solid cystic mass in ultrasound and CT, and this was giving rise to hemoperitoneum. The ruptured cystic component, though not clearly visible in this picture, was adherent to the peritoneum and was posteriorly going to retroperitoneum, transverse colon, splenic flexure, and was adherent to them. This mass was full of necrotic and solid areas inside. Right tube, ovary, and uterus were normal. So we proceeded with left salpingo oophorectomy. Adherent cystic mass could be separated from the peritoneum by gentle stripping. Complete resection of rest of the tumor tried, but small tumor mass extending to retroperitoneum was left behind, as further resection was not possible due to loss of planes and high vascularity. Partial omentectomy was done. The same is depicted in this diagram, where we can see a solid mass anteriorly, which was separated from the cystic mass, and this was giving rise to the hemoperitoneum. She received 3 Paxil transfusion intraoperatively, and rest of her post-op period was uneventful, and she was discharged on day 10 with hemoglobin 11 gram%. Initially on microscopy, pathologists gave the diagnosis of moderately differentiated Sertoli-Leydig cell tumor, but after detailed immunohistochemistry, negative reports of inhibin and calretinin totally eliminated the diagnosis of Sertoli-Leydig cell tumor, and the final diagnosis of ovarian microcystic stromal tumor was made based on the positive IHC for Vimentin, CD10, CD56, and Wilms tumor 1. PLAF was negative, which ruled out dysgerminoma, and AFP negative excluded the diagnosis of yolk sac tumor. Now I would like to invite Dr. Arvind Ahuja, sir, Professor, Department of Pathology, for his expert opinion on the histopathological slides.
Good afternoon, everyone. Thank you, organizers, for having me here in this interesting case discussion. Basically, we received this large tumor in a very young female, which was actually ruptured when we did a grossing. And in our mind, it was basically there were two differential diagnoses. One was a germ cell tumor, predominantly a yolk sac tumor, and the second one was a sex cord stromal tumor, basically Sertoli Leydig cell tumor, poorly differentiated. But on histopathology, when we reviewed, this is a slide which is a low power view, which is showing that the tumor was predominantly showing cellular spindle cell areas, and there were areas of cysts and congested vessels. As we can see in this photograph, there are basically low power photographs. So next slide, please. We will having a high power photograph to better appreciate the areas. Next slide. So this is a high power view. The cells were predominantly oval to spindle cells, and they were predominantly poorly differentiated. And based on this cellularity, we thought it could be a sex cord stromal tumor. Next slide, please. These were areas which were showing these microcystic changes. So these whitish spaces in between the spindle cells are basically microcysts. So we have a microcystic areas also. But microcystic areas can be seen in any of the germ cell tumors as well as in the sex cord stromal tumors. So at this point of time, we didn't had in mind the diagnosis of microcystic stromal tumor, basically because of this tumor is basically a benign tumor. However, in our case, we were predominantly thinking of a malignant tumor. So next slide, please. So there were areas of large areas of hyalinization also with compressed vessels. Next slide. And there were cystic areas also, these large cystic spaces we can see on the left side. So basically, and there were some myxoid areas also, which are on the right side of the picture. Next slide. So there were multiple sections were taken to rule out other components, but there was no other component except in one slide we could find out cartilage. Basically, it is a heterologous differentiation, which was a benign cartilage in one of the slides. Next. So after ruling out, after doing alpha fetoprotein and PLAP, we ruled out germ cell tumor, especially yolk sac tumor, and then we moved to sex cord Leydig cell tumor, and we did inhibin and calretinine, which was also negative. So we went through the literature and we find that microcystic stromal tumor can be one of the differential diagnosis, and it is usually positive for CD10 and CD56. So we did both the markers, and they both were strongly positive. As we can see in both the photographs, these cells are basically CD10 as well as CD56 positive. Next slide. They were also positive for focally for cytokeratin pan-CK, and WT1 was also focally positive, which is well known in this tumor. Next slide. So it was labeled as a microcystic stromal tumor. It is a very rare tumor with only less than 50 or 60 cases have been reported in the literature. And they usually behave like a benign tumor, except for one or two cases in the literature. But in our case, there was a capsular rupture and there was dissemination into the peritoneum. So probably this tumor is going to be behaving like a malignant tumor. So that was the case. It was a very interesting, and I am seeing this case first time in the 17 years of my experience, and we have not seen any case report from India till today. Thank you.
Thank you so much, sir, for this wonderful description. So our final diagnosis was microcystic stromal tumor, stage 4B with suboptimal debulking. With this diagnosis, we referred the patient to oncology center for expert opinion on need for adjuvant chemotherapy. But before she could receive any treatment, she again reported to RML hospital casualty with massive ascites associated with dyspnea and anemia after 6 weeks of surgery. The patient was stabilized by therapeutic ascitic tapping and received 2-unit PRBC as her hemoglobin was 8 gram%. On her PET CT, it showed gross ascites with metabolically active solid cystic mass of size 7.7 into 5.8 centimeter in abdomen and peritoneal lesions, likely metastasis or residual disease with mesenteric and omental thickening. There was no metabolically active abnormalities in large bowels or small bowels, mesentery, lymph nodes, or anywhere else in the body. Now the patient has received her first cycle of chemotherapy consisting of bleomycin, etoposide, and cisplatin regimen. The patient is symptomatically better after receiving this first cycle, and her next cycle is due for the end of this month. Now I hand over to Dr. Durgeshman for the discussion of this case. Thank you.
Good afternoon, everybody. Microcystic stromal ovarian tumor was first described in 2009 by Irving and Young, who reported 16 cases with a distinctive histology and immunochemistry, which lacked the morphological features of alternate sex-cord stromal, epithelial, teratomatous, or other germ cell tumor. And for this, they wanted a separate categorization of these tumors. WHO classified microcystic stromal tumor under pure stromal tumor in 2014 as a rare subtype. Characteristically, microcystic stromal tumor, they consider a triad of element, which includes the regions of microcyst, solid cellular areas with lobulated growth, collagenous or fibrous stroma, which forms the hyaline plaques. Immunohistochemistry plays a very important role in arriving at a diagnosis and to prevent the diagnostic errors. So microcystic stromal ovarian tumor, they are positive for Vimentin, WT1, CD10, CD56, which was consistent with our case findings too. They were negative for inhibin and calretinin. Sertoli cell tumor, granular cell tumor, thecomas, steroid cell tumor, which are kept as differential diagnosis, they are positive for inhibin and calretinin. In the review of literature, in 2009, Irwin and Young reported 16 cases. So by now, we have hardly less than 60 cases. Mariah Arafa et al. In 2021, they reported a case series of 57 cases. And in that, the mean age presentation was around 44 years in the age group between 23 to 71 years. Almost all of the tumors were unilaterally, except for one tumor, which was bilaterally, and in that, the left ovary was involved more than the right ovary. Presentation-wise, nearly 54% presented with pelvic mass, followed by abdominal discomfort in nearly 27%. In another series by Deng et al. In 2020, who reported 42 cases, according to the study, nearly 64% of the cases, they had mixed solid cystic components, followed by cystic and then the solid component in nearly 14% of the cases. The average size was around 10 centimeter. Smaller size, 1 centimeter was also detected. In the same case series, nearly 64% of the patients, they underwent oophorectomy with or without self-injectome or cystectomy. So by now, all the previously reported cases, they had shown to have good prognosis and uneventful outcome, but they have been exception to the benign behavior of microcystic stromal tumor. Our case was different, as she was the youngest patient to be diagnosed with microcystic stromal tumor at the age of 17 years. She had atypical presentation with a huge abdominopelvic mass, gross ascites, and right-sided pleural effusion. And in the post-op also, she had a recurrence of ascites with enlargement of the residual mass and rapid deterioration in her condition, and she required chemotherapy. Other than our case, there have been 2 more cases reported in the literature. In 2018, one case with recurrent intra-ovarian and extra-ovarian tumor was reported after 9 years of follow-up. Another case with omental metastasis was reported in 2021. However, both these cases did not receive any chemotherapy. So, microcystic stromal ovarian tumor, they have been recently described as subtype of pure stromal tumor where immunohistochemistry plays a very important role, as now more and more cases are being diagnosed properly with the help of immunohistochemistry. Still classified as benign, the malignant potential of this tumor cannot be ignored. The diagnostic criteria and the standard treatments still remain unclear. So these cases need a close follow-up in the postoperative period, and the future may throw light upon its malignant potential and the treatment option. Thank you so much. Now, for the next case, I'd like to invite Dr. Srishti, Dr. Kamna Datta to go ahead with the next presentation. Thank you so much.
Thank you, ma'am. Good afternoon, respected seniors. We often deal with ovarian masses in our practice. So today, I'll be presenting two cases of inflammatory tubo-ovarian mass where we faced a diagnostic dilemma, followed by an unusual final diagnosis. Our first case was a 38-year-old female who presented to our OPD with complaints of pain over the lower abdomen for 6 to 8 months and fever for 2 months. The pain over the lower abdomen was dull aching in nature, insidious in onset, gradually progressive, associated with heaviness, backache, bloating sensation, and constipation. She also had complaints of dysuria and increased frequency of micturition. It was not associated with any menstrual abnormalities. Fever that started 2 months ago was documented to be up to 100 degrees Fahrenheit, not associated with any chills or rigor. There was no localizing pathology that could be ascertained, apart from pus discharge from umbilicus, which was non-foul smelling and not associated with any pain over the umbilicus or any history of trauma. With these complaints, she presented initially to the surgery department, wherein she was worked up for her fever. Discharge from the umbilicus was sent for tubercular or bacterial growth, which were negative, and she was started on antibiotics. She was also diagnosed with UTI, which was again treated. On further workup, an ultrasound was done, which revealed a left complex adnexal mass, with which she presented to our department once her fever and discharge subsided. She is para 2, living 2, with 1 cesarean section 7 years ago, has regular menstrual cycles, and is a known case of hypothyroidism, well controlled on medication. At the time of examination, her general physical examination revealed mild tachycardia, with no other cardiorespiratory or general abnormality. Per abdomen examination revealed a flat abdomen with a central dry inverted umbilicus and a healed infraumbilical scar. On palpation, there was no discharge coming from the umbilicus. An ill-defined firm to cystic mass of approximately 12 by 10 centimeter was palpable over the suprapubic and the left iliac fossa region. Lower limits could not be reached. It had restricted mobility and was non-tender. There was no evidence of any free fluid or any other organomegaly. External genitalia and per speculum examination were within normal limits, and on per vaginum examination, a firm regular cervix was palpable, directed downwards and deviated to right. Same mass could be palpated through the left fornix, which was firm in consistency with ill-defined margins, smooth surface, and restricted mobility. Uterus could not be felt separately, and the right fornix was free and non-tender. She was then directed to certain routine investigations, which were within normal limits. The initial ultrasound revealed a multiloculated hypoechoic complex mass in the left adnexa extending into the POD of approximately 11 by 8 centimeter, with a normal right ovary and a normal uterus. For further detailing, an MRI was done, which revealed a large multiloculated thick-walled mass of 12 by 9 by 11 centimeter, along with a dilated tubular lesion of 5 by 6 centimeter in the left adnexa. The contents of the mass were hyper-intense in T1 imaging and hyper-intense at T2 imaging, suggestive of a benign or an infectious etiology. There was also a right-sided 4 by 4 centimeter hemorrhagic cyst, and the uterus was normal in size. There was a blind urachal sinus in the anterior abdominal wall, suggesting that the discharge was coming from the infected urachal sinus and not from that, and with no connection with our tubo-ovarian mass. To rule out malignancy, certain tumor markers were done, which were within normal limits, and the endometrial biopsy also did not reveal any abnormality. With the provisional diagnosis of a complex tubo-ovarian mass, patient was taken up for laparotomy. Intraoperatively, it was a large 15 by 12 centimeter mass in the left adnexa extending into the POD with dense adhesions to the adjacent structures. Left ovary and fallopian tube could not be visualized separately. Right ovary was bulky and the right fallopian tube was edematous. So with the help of surgeons, the mass was dissected out and a total abdominal hysterectomy with bilateral salpingo-oophorectomy was performed. The mass on cut section revealed a multiseptated structure with purulent fluid of yellowish green color. The purulent fluid was further investigated, which revealed mildly raised ADA of up to 61 units per liter, but had no evidence of any tubercular, bacterial, or malignant growth. Her post-operative period was uneventful. After 1 month, we encountered another case who presented to our emergency. She was a 35-year-old female who presented with complaints of pain over the lower abdomen for 15 days, fever for 1 week, and vomiting for last 2 days. Pain in the lower abdomen was sudden in onset, sharp, acute in nature, non-radiating, and gradually increasing in intensity. Associated with foul-smelling discharge from the vagina, fever was high grade, and she had multiple episodes of vomiting in the last 2 days. She is para 2, living 2, abortion 2, with copper T in situ for last 3 years and has regular menstrual cycle. At the time of examination, her general physical examination was normal. Tenderness was present over the lower abdomen, and per speculum examination revealed a foul-smelling mucopurulent discharge. On per vaginum examination, there was a 7 by 5 centimeter tender firm mass with ill-defined margins and restricted mobility in the left adnexa. The emergency investigations that were done revealed hemoglobin of 9.8 and a total leukocyte count of 15,400. Ultrasound done revealed a well-defined heterogeneous mass of 7 by 8 centimeter in the left adnexa. On color Doppler, the possibility of torsion could not be ruled out for the mass, so the patient was taken up for an emergency laparotomy. Intraoperatively, a 6 by 7 centimeter mass was seen in the left adnexa and the pouch of Douglas, adhered to the adjacent structures. Fundus and the anterior surface of uterus were identified to be normal. Left ovary and fallopian tube could not be visualized separately. Right ovary was normal and the right fallopian tube also appeared to be edematous and friable. During dissection, foul-smelling pus drained. Thus, after the removal of the tubo-ovarian mass, right salpingectomy was performed. The fluid that was sent revealed a bacterial growth of Staphylococcus aureus with raised ADA of up to 520, but no evidence of any tuberculosis. Her rest of the postoperative period was uneventful. Now I would like to hand over to Dr. Kamna for further discussion of the case. Thank you.
Thank you, Srishti. Looking at her clinical presentation and intraoperative findings, we had a strong suspicion of tuberculosis. But in view of the paucity of any conclusive evidence, we waited for the final histopathological report. Good we waited because the histology report came out to be xanthogranulomatous inflammation. Rarity of this disease made us review the literature, and we found that this is an uncommon, non-neoplastic, chronic process of bacterial inflammation, and the affected organ is destroyed by massive cellular infiltration of foamy histiocytes mixed with multinucleated giant cells, plasma cells, fibroblast, and lymphocytes. There are also areas of necrosis. The causative organisms implicated include E. coli, Proteus, Staphylococcus, Salmonella, bacteroides, to name a few. And the various predisposing factors identified are inadequate antibiotic therapy, endometriosis, leiomyoma, intrauterine contraceptive device, history of surgery like cesarean section or any other uterine cavity surgery, and pelvic inflammatory disease. Both our patients had high-risk factors. Our first case, due to her chronic nature of disease, had received often antibiotic therapies. She was also a case of previous cesarean section, and her histopathological report revealed endometriosis in the contralateral ovary. Our second case, who was suffering from pelvic inflammatory disease, had a copper T inside, and her pus culture revealed growth of Staphylococcus aureus. Though the most commonly affected organs are kidney and gallbladder, the female genital tract is not spared. It is usually unilateral, The destructive and mass-forming tendency of this disease makes it difficult to distinguish from malignancy, both clinically and radiologically. Due to local destruction and necrosis, there is possibility of chronic abscess formation, and which can then mimic tuberculosis. Also, the CA125 levels may be normal or raised, and intraoperatively, invariably, dense adhesions are found to the surrounding structures, raising again the suspicion of malignancy or a chronic inflammatory disease like tuberculosis. So the first case of female genital tract xanthogranulomatous inflammation was reported in 1976. This was in Philadelphia, and this patient, who was 26-year-old, was operated for fibroid uterus with pelvic inflammatory disease. She was in this, the disease was in fact then termed as inflammatory pseudotumor. Since then, 92 cases have been reported worldwide. And considering Indian scenario, we have 34 cases in 1995. Considering the prevalence of tuberculosis is high in Indian setup, almost 17 cases of the 34 cases reported were mimicking tuberculosis. Most of the patients presented with pain abdomen, fever, and lump. The most common presentation, the age group of presentation was late reproductive age group, though the youngest girl reported was of 3-year-old. So tuber-ovarian masses can be fungal, tubercular, or of bacterial origin, which may be acute or chronic. And due to overlapping of clinical features and laboratory parameters, there is a definite diagnostic dilemma. In fact, the clinical imaging may also not help us differentiate between them distinguishedly. So we again look at our pathologist friend, who may be confused in initial gross description, but the histopathological evaluation will help in clinching the diagnosis. In tuberculosis, we may find multinucleated giant cells with caseation. Acute bacterial infection will show predominance of neutrophils along with neovascularization. In a slide of malignancy, cellular atypia along with nuclear pleomorphism will dominate. And in xanthogranulomatous inflammation, there will be lipid-laden macrophages along with lymphocytes and fibroblasts. These are the slides of our case. This slide shows an organized granuloma with a thin rim of fibrosis, showing that there is no capsule in the lesion. On further magnification, vacuolated foamy macrophages were seen along with plasma cells, lymphocytes, and spindle-shaped fibroblast. On higher magnification, the morphology was even clear, and we can see vacuolated foamy histiocytes and multinucleated giant cells, and now with a few congested blood vessels. So due to dilemma in diagnosis with clinico-radiological presentation, the mainstay of management remains surgery, followed by the final histopathological diagnosis. Although adequate antibiotic therapy may have a positive response, the disease can get lethal if it progresses to systemic inflammation. Thus, surgical removal of the primary foci along with the infective pathology is the preferred approach. Awareness of this condition and a high index of suspicion among clinicians, radiologists, and pathologists can help in early diagnosis and appropriate management of this potentially destructive disorder. Thank you so much. We can now
thank you everyone for patient hearing. And now the presentation from the department is over. I thank all my faculty members for their hard work and valuable time for this presentation. So now the presentations are open for discussion.
Thank you, Dr. Ashok, for such a nice presentation and selecting such nice cases where there was a lot of learning for all of us. So now, as a judges, I would like to invite Dr. Harsha Kula, Dr. Shushma Sinha, and Dr. Meenakshi Ahuja. I hope they have already logged in.
Yes, thank you. I'm Dr. Harsh Kullar and one of the judges. So first of all, I must congratulate RML hospital team for presenting such interesting cases. And now these first two cases, one was of that recurrent ovarian torsion, and the other, both patients were 17 years old only. And the last case, there were two cases, 38 years and 36 years. Now the thing is that ovarian torsion, that is more common in the young patients. I just want to know in the history, this, I think whosoever presented, whether the patient had any PCO symptoms or she was PCO cases, because in PCO cases, the chances of getting ovarian torsion are more. I think that was not mentioned. I would like to know that.
Ma'am, there was no such evidence.
There was no such evidence. So there was no history of PCO. Because whatever the cases, and in that case, it was a recurrent because first time it occurred on the right side, and the next time when she had come, I think first time on the left side, and next time when she came, it was on the right side. And of course, you people have done a wonderful job by doing this thing, oophoropexy. And I think she must be doing well. And people have reported this thing, repeated the ultrasound also after 2 months, and that was showing the normal ovary. It was beautifully this thing presented, this case. Now in literature, they have reported so many cases, different techniques by fixation of ovary to posterior abdominal wall, anterior abdominal. This has already been discussed. And plication of the uterovarian ligaments. I just want to know that in young patient, if she comes with this thing, torsion of the ovary, 17 years as you told, so in the first sitting only, should we plicate the tubovarian ligament? Uterovarian ligament.
I've not heard the cases. How can you ask questions?
Yes, ma'am. We need to evaluate the uterovarian ligaments on the contralateral side. And if they are, there's more of laxity and they are elongated, it is better that we do a fixation rather than she comes the next time with a recurrent torsion.
That is
so
what.
this has commonly been seen, particularly in the adolescent patients.
And we should see that this uterovarian ligament that is not very long, because
very
long this thing that chances
it's very common to see.
Yes, it's very important. Yes. So other two judges, they want to ask any questions, so they're most welcome about this first case.
Sushma, unmute yourself.
Yeah, I am Dr. Sushma, and thanks for the opportunity. Yeah, all the cases that were selected were simply wonderful and managed and narrated very nicely. The content was very good. And I mean, the sequence of management was spot on. I just wanted to know about that second case, that microcystic stromal tumor. I mean, I believe that it is mostly benign tumor, and only one case prior to this was reported as malignant, where it was disseminating to the omentum. So how do we decide on the modality of treatment? How do we decide about the chemotherapy? What were the factors?
Dr. Sushma,
yeah.
That's why this case has been presented, till about 1 year back. It was said that this is a benign tumor, doesn't require follow-up, doesn't require chemotherapy. And as Dr. Durgesh said, that there are total 57 cases reported in the literature and none from India. So this case was unusual, and I think the credit goes to our pathologist friend coming up with this diagnosis. The two cases which have been reported unusual in the literature, one represented 9 years after initial diagnosis with metastasis, with recurrence, in fact. And the second one had omental metastasis. And as per the literature reviews, none of them received chemotherapy. So this is as late as 1 year. So there are no guidelines. And in fact, as it's a subcategory of sex cord stromal tumor, it's a stromal tumor. So in fact, we talked to the persons who are giving chemotherapy. Initially, they were not sure like which chemotherapy to give, because if you think it's a category of sex cord stromal tumor, like Sautali, and then they would be given cisplatinum-based chemotherapy. But they decided, they reviewed the literature and decided that let's give bleomycin, etoposide, and cisplatin. That's what she's receiving. So nothing is known about this tumor. It's only like more cases are reported with this. It's immunohistochemistry which clinches the diagnosis. So in our case also, initially we thought it's Sertoli, but immunohistochemistry changed the diagnosis. So maybe in next few years we'll have more cases and somebody will come up with the best regime which is possible. But our patient has responded. There was so many things unusual about this case. She was young. She presented very late. And within 7 to 8 days of admission, she had rupture of the mass and collapsed almost in the ward. Like, we took her for laparotomy immediately, and we don't know. I mean, maybe, we'll give the follow-up after a few years. After first cycle, she's better, the ascites is less, and maybe we'll review the mass size after 2-3 cycles. So we don't know. What would be the best possible treatment
Actually,
for these cases?
you are very lucky to have such a nice diagnosis from the histopathologist. And I wish many more centers do come up with this, immunohistological assay, and then more and more cases will be picked up. So the
that's right.
treatment part will become much more clear later on.
I also agree with you, because histopathologists, they have done a wonderful job by doing all the same tumor markers and all, and coming to this diagnosis of this thing. And one thing more I would like to add, Dr. Indu, that first case which was discussed, ovarian torsion, last year, I think in the AOGD meeting only, our Dr. Punita also presented a series of cases.
Yeah.
There was a series of 28 cases in 5 years' time. And in all cases, it was the oophoresis was done laparoscopically. And that paper is under publication, and it will shortly come out with that.
Yeah, Punita did a wonderful job. I know, I remember that. Right. So we must remember oophoresis and...
Yes. True. Then third...
Is there any other comment?
Yeah, I think a very, very wonderful presentation of cases, and especially the last 2 tuber ovarian masses. I think it's a lesson to be learned, because after seeing such high ADA, we don't even wait for histopathology, and even if we don't get a TB PCR, we always empirically start ATT. I think this is a lesson which everybody must learn, that you must wait for the histopathology. You might get a diagnosis which is not tuberculosis. Dr. Sunesh has raised his hand.
Yeah, he has raised his hand.
Please unmute him, Shivam.
Nice to see you, sir. Dr.
Yes, sir.
Good evening, sir.
Welcome.
Thank you. The first patient who had a torsion second time, do we have histopath of the first surgery? First time salpingo-oophorectomy was done on her, and she was carrying a discharge slip.
Neha?
So, Dr. Renuka, you can, Dr. Neha, can you?
Histopath didn't help much. It just said a necrotic tumor, necrotic hemorrhagic tumor, 11 into 14 centimeters. No diagnosis of tumor as such.
Actually, in young patient, the commonest kind of tumor we see is a dermoid, which is likely to undergo torsion, and it could be bilateral. But after having undergone torsion with a lot of hemorrhage inside, it is difficult to diagnose, and maybe one can even miss. Let's hope she remains all right after this second surgery. The second patient, preoperatively, she had raised CA-125 and raised alpha-fetoprotein. So when she presented
not alpha protein.
Achha.
CA-125 was raised.
And we hadn't done her SCG.
It was also raised, Indu. It was
slightly raised.
Alpha-fetoprotein was
SCG was normal. Borderline raised.
So when she presented with the recurrence within, say, 6 weeks, did we repeat her tumor markers again?
No, we did a PET CT, sir. We didn't do tumor markers, because by that time we had the diagnosis. The histopathologist had given us a diagnosis of stromal tumor, so we didn't repeat it. And there was no evidence of hormone secretion as such.
Quite often in a big tumor, there may be another area which has a germ cell tumor. I'm sure pathologists have looked in detail. Tumor was so big and there were necrotic area, but there's a strong possibility that she had a mixture of histopathology. And the way tumor was enlarged, there was a retroperitoneal extension. It had a malignant behavior.
Yeah.
Yes.
Thank
So,
you.
Dr. Arvind,
Yeah,
Dr. Arvind,
I like to comment. I like to comment. Thank you,
Thank
sir,
Yes,
you.
for a
yes.
nice comment regarding the basically grossing of the specimen. Actually, it was very large, around 20 centimeter in size, and we did thrice. We took thrice sections, and they were about 25 sections from the tumor. So that we were also concerned that it is a malignant tumor, so we should not miss any germ cell component or any other component which was lying in some of the corners of the tumor. So we did extensive sectioning, and there was no such tumor or germ cell component in the basically 25 sections we have examined.
Thank you. Young
Sudha
patient.
Salan also raised.
Sir, have you ever come across such a case? Because we were not sure which chemotherapy regime to give, because there is no such case in the literature in who has received chemotherapy. Dr. Suresh, sir.
The tumor actually, clinical behavior is also very important. This term is actually relatively new, but we have often seen such big tumor in adolescents. And the very fact there was some tumor left behind, she had qualified for chemotherapy. Let us hope
Yes,
with
sir.
BP she improves. Probably that is the best approach in young patients.
Yes.
And there was rupture of the missing tumor also by removing it, I think. So that is what.
Yes. No, not while removing, ma'am. She collapsed in the ward. She collapsed and ruptured, and there was
That
no
is where they
peritoneum.
ruptured.
So we took her for laparotomy in the evening, because she had collapsed. So it was an emergency laparotomy.
Right. But all the cases were very interesting. Must congratulate you once again.
I think Dr. Sudha Salan and Dr. Dinesh had also raised their hand. Shivam, can you unmute them?
Yes.
Yeah.
Dr. Sanjeevani is also raising.
Very nice cases on a single topic, that is adnexal masses, and all very different. Thanks for discussing so well. This was about the first case. It is interesting to know in so many patients the torsion recurs in spite of the oophoropexy. So we wonder what is the best method for oophoropexy on the other side, or the same side if you are just doing the cystectomy. So the latest what we know is a hot dog in bun fixation. That is, you fix the ovarian ligament to the round ligament. You go through the mesosalpinx, like tube remains above, and you fix the ovarian ligament to the round ligament. Probably it may have better prognosis.
Madam, this was done for this patient also, and we are hoping that she will not come back with the same problem.
Great, okay, nice.
So if Dr. Sudha Salan would like to say something, I'll wait for her first. Dr. Sudha? Okay, so I think I'd just like to really, mention that this was a really good session full of learning, and the second and the third cases are a little infrequent as far as ovarian torsion or adnexal torsion is concerned. We may encounter it anytime, and just want to highlight that there is a condition in which there may be intermittent torsion. So if a girl presents with pain which gets relieved on its own, so it might be correcting, but that doesn't mean there's no torsion. And in this connection, there is one sign I had read about, and that seems very interesting, and that's called the flipped ovary sign on ultrasound. The flipped ovary sign is more reliable if there is an ovarian cyst or there is a dominant follicle, and on a subsequent ultrasound, you see the orientation of that cyst, whether it was on the lateral side or the medial side. So if it's the ovary flips by on ultrasound seen by the same method, then it could indicate that it is beginning to twist. That's one thing. And I also wanted to ask Dr. Ayushi and Dr. Neha that you took up the patient for laparotomy in that twisted.
Yes, ma'am.
Yeah, but could you have chosen laparoscopy in that case?
Actually, it was done during the emergency hours, and ma'am, we don't have provision of laparoscope
All
during
right.
an
Okay.
emergency. Otherwise, the
And
best technique would have been laparoscopy.
yeah. So in one case, you had right-sided ovarian tube removed already. So at
Yes, ma'am.
any cost, you would not like to have the ovarian function of the left side of the other side
Absolutely.
compromised. So if it's a torsion, it was a torsed at
Yes, ma'am.
Necka
It was a torsion, ma'am. 2.5
within
turns with it.
2.5 turns, and it was
Yes,
due to
ma'am.
an ovarian cyst, was it?
Yes, ma'am.
Okay, so you remove the cyst and fix the ovary, right?
Ma'am,
So, yeah, so if it's a tossed ovary, then you may not be able to diagnose it very well on ultrasound and Doppler or any other method. But when you see it under vision, of course, it's the best. You know, you may have a bluish necrotic looking ovary. And now, like you rightly mentioned, that it is not to be sacrificed just because it's necrotic and bluish looking. Most of them are salvageable. So the important point I wanted to ask you here was, Dr. Neha, that during the surgery, whether laparotomy or laparoscopy, when you untwisted the ovary and you remove the cyst, it may still appear bluish,
ma'am, actually,
for some time.
Yes.
So,
So we don't have to worry. We don't have to worry about the bluish discoloration. It gradually over time gets corrected and it regains its normal, because there have been studies which they have put in a scope after like 4 weeks and seen that the ovaries have become normal.
Yes, but when is the reperfusion likely to be established, you know, in the ovary after you have detossed it?
Ma'am, it
So,
starts
I mean, wow, I'm just saying from this angle, yes. So that could you take it easy and observe during surgery and note down whether the color has, reestablished, and so make a note of that rather than just our finishing detorsion, cystectomy, fixation, and coming out. So for a few minutes we can observe, and normally it may take from 1 minute to 30 minutes, but normally you will see a reperfusion soon.
Yes, ma'am. True.
And can I add something over here?
Yes, sure.
Ma'am, they say that for a matter of 10 minutes, we should give 100% oxygen to the patient while detorting the ovary. And then we can put some hot mops and at least give 10 minutes time and see whether the reperfusion has reestablished.
Yeah,
and
so this is very important. So this is, just to not make haste at that time, and not just remember in the procedure that all we've got to do is open up or put a scope, detoss, remove cyst, fix ovary, and come out, because we can spend 10 minutes observing. And people have used fluorescein dye given intravenously earlier to see the reperfusion under that I don't know what they use, ultraviolet light, and they have used indocyanine green also in the infrared light to actually see that reperfusion has begun, and that's how they're able to say that it takes this much time for reperfusion. Agreed that we don't have to sacrifice bluish and necrotic looking ovaries, because by and large 80% of them will return to normal, and the AMH levels will be maintained, and the fertility will be preserved. So I think the take home one point from here is that observe for a little while, because there's no dashing hurry.
Right.
Observe for a little while. Thank you so much for all the wonderful presentations. I think there won't be time for more points from my side, but if anybody else, most welcome.
I would like to add something. As Dr. Achla said, ADA levels in our second case was found in the range of 520. But just a point which we can all remember, whenever we send pus for ADA, the levels will be very, very high because it is a concentrated fluid. So we should never start the treatment for tuberculosis based on the ADA levels in the pus. Thank you.
I would like to say that I think one should send it for culture also, because culture report comes after 6 weeks. So that will be the diagnostic for tuberculosis.
Yes, ma'am.
Just to depend on this ADA levels, and I don't think that will be the final.
Madam, it is always sent AFB and
so
culture also sent. Yes.
What was the report in this case? Negative.
Ma'am, report in this case the tuberculosis workup was negative.
Negative. Okay. Thank you.
So if I think anybody else
Can
wants to say something,
if can I request Dr. Kamal Bakshi, one of my mentor, to give her comments, or
I must congratulate the whole team. The beauty is that in a government hospital, the way how rapidly the patients were diagnosed, managed, and even the histopathology. So it points out that as far as the teamwork is very important. Now, Dr. Khanna was saying very nicely, we had a young girl, and that was on a Sunday, 12-year-old, who came with acute pain, and she was tossing. So we did the ultrasound, and the radiologist said, the whirlpool sign is absent, and I think, ma'am, we can wait. I said, the way this patient is behaving, we have to operate. Anyway, and she had a huge para-ovarian cyst. So when we did a laparoscopy, Dr. Lalita Badwar was along there. This patient had 3.5 turns, and the whole ovary and the tube had 3.5 turns, looked, necrotic, deep purple color. So I said, Lalita, let's first remove the para-ovarian cyst, give the time and note. And we noted the time, as you all were saying, how much time. The color gained, because it was a huge cyst and it took us 40 minutes, and that color bluish first, the color faded and then later. So it took about 30 to 40 minutes. So it may take time, And then this very girl, because she was not having any periods or another, we did her ultrasound at the age of 1 year, 2 years, and her ovary was very well functioning. So that is one thing. And I must say now more and more diagnosis is being made because everybody is aware. Now coming as far as the stromal tumor is concerned and about the TO masses, again, they are very nice. But I will say that nowadays histopathology, unless you do the various tests, you cannot make a diagnosis. So in this day and age, it is very important to do all the tests, before we come to the diagnosis. But what I would say, I'm so impressed with this younger generation in their dynamism, their enthusiasm to read and to come to the good diagnosis. So we have good young leaders. Dr. Ashok here, I must say, Dr. Harsh Kullar is there, Dr. Achla is there, Dr. Khanna. They all have joined together. And I always feel AOGD is such a pleasure. You learn every day. And that is what keeps us living and very happy, because you see that how many new things are coming up. And COVID has brought us together. Thank you all.
Thank you.
Thank you, madam. Thank you all the seniors for their comments about the case presentation, what we have done from RML Hospital. Dr. Achla Batra, you want to conclude?
I think Monica would give a vote of thanks to everybody. Monica.
Thank you, everybody, for a wonderful and very, very interesting AOGD monthly clinical meet. And especially the 3 interesting cases, which were, gems of, in fact, new insights into adnexal masses. And I'm sure we all agree with the pearls of wisdom given by our loving seniors, Dr. Sanjeevni, Dr. Kamal Bakshi, Dr. Sunesh Kumar. We always get enlightened with the, these little tricks, tips and tricks which are given at the end. Thank you all, Madam and Sir. And special thanks to our judges for asking the inciting questions and making it even more interesting. Last but not the least, all the audience who have joined, and it's a good number of 80 till the end. So that was very heartening to see. And of course, at the end, our Encure Pharma, who's been our academic partner for the monthly meetings. So thank you, one and all. Thanks once again for the interesting meeting.
Thank you.
Thank